Hello, everyone. My name is Mostafa Abdeen. I'm a resident physician, and today we will discuss the interpretation of CBCs. So, before we dive into CBCs, we need to have a good definition of what a CBC is. So, a CBC is a complete blood count. Some people like to refer to it as a complete blood picture. However, what a CBC is that it's a series of tests. So it's not a single test. It's a number of tests that we collect all the results of these tests within one piece of paper, which we term that paper as a CBC. This piece of paper gives us information that allows us to evaluate the composition of blood. It makes us capable of understanding the cellular components of blood and understanding if there are any certain abnormalities within it. We like to look at the composition of blood in terms of concentrations. So you'll always see that any count would be presented as maybe 11,000 cells per millimeter cube. So that's a concentration. Now, if I may ask you, people who have their videos on, can we please close the video? Thank you. So let's go back. So as I said, a CBC, again, is just a piece of paper that gives you a summary of a series of tests. Each test is giving us an idea about a cellular component of the blood, and we evaluate these cellular components in terms of concentration. Now, the only issue that you might arrive with whenever you look to a CBC is, as I said, that we look at things in terms of concentration. So if maybe a patient had acute hemorrhage, they had any cause of blood loss, then the CBC will not be very accurate at some of its components, because again, we read everything in terms of concentration. So if you lost a lot of fluid, then it means everything will seem falsely higher than they actually are. So this, whenever I'm going to say the term relative, this is what I mean. It means is the concentration is high, but it's not really, the cellular number is not really high. It's probably because there was fluid loss, okay? So again, so what does a CBC provide information about? So this is a good chart that we can look into. So again, remember, the CBC gives me an idea about the blood composition, and the blood is mainly formed of cellular components. All of us know them: the red blood cells, the white blood cells, and the platelets. And then the CBC is a complete blood count, so it gives me a good idea of the cellular components within each of these subgroups. So within the white blood cells, we have two main subgroups, the granulocytes and the agranulocytes. So granulocytes, these are type of white blood cells, as you see from the diagram, and they are characterized by the presence of granules. So they're granulocytes because they have granules. And these granules are just small packets of enzymes and proteins in the cytoplasms of these cells. So these cells are very important for the body's immune system. They're white blood cells, and they play a very important role in defending against infection, especially when we're talking about bacteria, fungi, and parasites. We can then further classify these granulocytes into three different types of cells, and we like to term these different types of cells based on their staining properties. So if we stain these cells and look at them under a microscope, each of them will give us a different property than the other. So for example, eosinophils, if they are stained by an eosine stain, they will start looking very bright red under a microscope. So they're called eosinophilic. Now, the word phil, P-H-I-L, or the suffix phil, if that's the right way to say it, that means loving. So eosinophilic means that it loves the eosine stain, and whenever it's stained by eosine, it would look bright red. So the basophilic stain, that if it's stained, it will be basic, and basic always appears blue. So the basophilic stain is going to appear blue under the basophilic cells are going to appear blue under the microscope. And then we have the neutrophils, which are going to stain neutral link. That's why neutral pink. That's why they are called neutrophils. So again, the granulocytes are these white blood cells. They're non-specific. They're not part of your adaptive immune system. They're part of your innate immune system. They have granules within their cytoplasms. These granules serve to contain proteins and enzymes, which are an important part of your immune defense. And we start to look at these granulocytes in terms of how they are stained. So neutrophils, they stain neutral pink, eosinophils, they stain bright red, and basophils, they stain blue. So that's where the names come from. And then on the opposite side, we have agranulocytes, and the word A, as in whenever we say, for example, asexual reproduction, means non-sexual reproduction. So agranulocytes means they don't have granules, and we have monocytes and lymphocytes. Lymphocytes are what form your adaptive immune system. So everything else is part of your innate immune system, okay? And then we move on to the RBCs. So the RBCs, there are no different types of RBCs. You just have RBCs, red blood cells, okay, or red blood corpuscles. So, and whenever we assess them, there are different measurements that we look at. So we look at the mean corpuscular volume. Well, the word corpuscular means body. Remember, when someone is dead, we call the body a corpse. So mean corpuscular volume means the average volume of a single red blood cell or of a single red blood corpse or a single red blood body. That's what it means. The mean corpuscular hemoglobin is the average hemoglobin within each red blood cell. So this gives us an idea. Now remember, the MCV, or the size of the RBC, is giving us a very good idea on whether the body had enough ingredients to create RBCs. So if you're lacking iron, for example, which is important for creating RBCs, your body is going to create smaller RBCs. So this is giving us a good idea on the raw material within the body. And then after that, we have the mean corpuscular hemoglobin. This is giving us a good idea on the function of each of the RBCs. Because remember, hemoglobin functions to bind to oxygen, and RBCs function to deliver oxygen to the rest of the body. So if you don't have hemoglobin, or you don't have enough hemoglobin to bind oxygen, then your RBCs aren't as functional as they should be. So the mean corpuscular hemoglobin is giving us very important information. Then we have the mean corpuscular hemoglobin concentration, followed by hemoglobin in general and hematocrit, which we will be discussing within the next slide. Just for now, just know that hematocrit test is just a simple blood test that measures the percentage of red blood cells in your body. Okay, so that's about it for an overview. So let's move on. So when should we order a CBC? So there are many reasons for you to order a CBC. This includes maybe trying to identify anemic patients. So remember, anemia is a medical condition, and anemia occurs when a patient has maybe a lower number of RBCs than normal, or they have a lower hemoglobin than normal. So for you to look at a CBC, if you can spot that the patient has a low hemoglobin, that's enough for you to say that they have anemia. If they have a low RBC count, that's enough for you to say they have anemia. If the patient has a low hematocrit, that's enough for you to say they have anemia. So you don't have to see that the patient has low RBCs and low hemoglobin and low hematocrit. One is enough. That's why you need to say that the patient is anemic, okay? So as I said, anemia is just a medical condition when a patient has low RBCs, a patient has low hemoglobin, a patient has low hematocrit, and it can lead to the reduced ability for the patient to carry oxygen or for blood to carry oxygen to the body's tissues. So if you're not delivering the needed oxygen to your body's tissues, you're going to have symptoms such as fatigue, weakness, shortness of breath. You're going to have pale skin. So there are many different causes of anemia. And usually whenever we're looking at the RBCs at a CBC, what we're doing is that we're trying to identify what is the cause of anemia in a patient. Followed by that, we need to identify patients who have bleeding tendencies. So we need to assess the body's ability to coagulate and form thrombi. So if such ability is weakened, then it means that the patient is most likely to bleed. Some of the patients have diseases which would put them in a state that is hypercoagulable, which means that they're at a larger stretch for getting emboli at vessels where they don't want to get embolized, okay? We can use it as a preoperative test, which means that we can do it before surgery to assess whether the patient is likely to survive an invasive surgery or not. So remember, whenever you have a patient in the OR, it means that they are likely to bleed large amounts of blood. So it makes sense that you would assess their blood and their ability to coagulate and form thrombi before you start going into surgery. You need to identify also, it helps us identify patients with infections, especially when you look at the white blood cell counts. So Again, the pattern of your body's response to an infection, or the way your body responds to a certain infection, let it be that maybe you have a high number of basophils, but nothing happens to the eosinophils and nothing happens to the neutrophils, for example. These different patterns that we get on a CBC can sometimes guide the physician into narrowing down their diagnosis and properly choosing the correct medication. Sometimes we use CBCs to follow up on chemotherapy and radiation. So I guess all of you know that chemotherapy and radiation have very drastic effects on the bone marrow. So I just want you to remember that the bone marrow is the site of blood cell production. So if you're giving patients any treatment modalities that would affect the bone marrow, it is only wise to keep an eye on the blood count. So some key messages that you should know, just as general knowledge. Just need to know that patients do not need to fast for a CBC. That you can have a CBC at any time of the day, regardless of when is it the time that you last had food. And whenever we withdraw a sample, we put it in a tube with a chemical that is called EDTA. Now, EDTA is a chemical which prevents the sample from clotting. So it just keeps the blood in a liquid state and makes us capable of doing the necessary tests on it. So what's the procedure? How do we withdraw blood from a patient? Now, withdrawing blood from a patient, that is called a phlebotomy. And what we do is that we withdraw blood from a vein. We start by cleaning the puncture site with an antiseptic. I'm 100% sure that all of you have either seen this or have been subjected to this at some point. So what people would do is that they start looking for a vein, then they clean the puncture site with an antiseptic. They apply pressure around the upper arm with an elastic band, which serves to act as a tourniquet. And then they start inserting the needle in the vein. Blood is collected in the tube, which has the EDTA, and then the elastic band is removed. I just made this and all of this in bold because I've seen this many times with people who just had or with people who are just taking their first blood sample. It seems that everything is intuitive, except for this, because it seems that whenever people start the first time for taking blood, they know that they need to look for a vein, and they have the small tissue to clean the site with an antiseptic, and they have the elastic band to understand that they need to apply pressure with it. So because they have the tools next to them, they understand intuitively that they need to use them, and they know that they need to put the needle in a vein, and the tube already has EDTA. So what happens is that people come to here, or like people arrive to this point, and everyone becomes so happy that they were capable of withdrawing blood for the first time. They remove the needle before removing the elastic band. So what happens for the patient is that they start bleeding profusely, and the scene isn't nice. People get very scared when whenever they're in this situation. So just please remember, you need to remove the elastic band before you remove the needle. That's the only tricky part for newbies whenever you start taking or withdrawing blood, okay? And after that, you just give the patient a piece of cotton or a piece of gauze, and they cover the puncture site, okay? So before we proceed, does anyone have any questions so far? Is everything clear? If everything is clear, please tell me. If it's not, also please don't, okay? So everything is clear. Okay, that's good to know. Okay. So let's proceed. So I'm pretty sure that a lot of you saw this for the first time and they were a little bit overwhelmed. Do we need to learn everything within this diagram? Well, the answer is no. You don't need to learn everything within this diagram, at least for the sake of your upcoming exam. So this diagram describes hematopoiesis. So or the word hemato means blood. Because remember, the study of blood is the discipline of hematology, okay? So hemato means blood. Poiesis means to produce. So hematopoiesis is a process which describes how different cells within blood have evolved from a single stem cell. So basically, whenever you look at this diagram, at least for the purpose of your exam, all you need to realize is that the B cells and the T cells, or the B lymphocytes and the T lymphocytes, they arise from a lymphoid progenitor cell. Okay, everything else arises from a myeloblast. So that's it. That's all you need to know. T cells and B cells, lymphoid cells, or like they arise from lymphoid stem cells. Everything else, myeloblasts. That's all you need to know. Nothing more than that. okay? And everything in the blood stems from stem cells. That's just basic info. Can you view the question for each slide and how it will come for us on the coming exam? Again, I'm not within the inner circles of how the exam is created. So what I'm capable of is trying to explain everything as at the best of my abilities. I'm more than willing to take any question repeating anything, but I don't know exactly how questions will be formulated. So please forgive that. I won't be able to do that. So again, so let's proceed from here. So this here, or this slide here, just serves as a reference. However, I'll just rather explain everything through the upcoming slides as we understand the utility of each measurement rather than throwing these numbers at you without them making any sense, okay? So here we're going to discuss the leukocyte differential ranges. Now, a leukocyte, the word leuko means white, the word cyte means cell, so a leukocyte is a white blood cell. And remember, these are the cells that form the white blood cells, which are the neutrophils, the lymphocytes, the monocytes, the eosinophils, and the basophils. I like to remember them with the mnemonic, never let me eat bananas. Okay, so never let me eat bananas, neutrophils, never let lymphocytes, me monocytes, eat eosinophils, bananas, basophils. Okay, and it's actually quite simple, at least when I look at it, to remember the references, because all you need to remember is the percentages, not the absolute ones. So I like to remember, so neutrophils are 40 to 60, 40 to 80. So I remember the number 60 because it's in the middle. Lymphocytes are supposedly they should be 20 to 40, not 25 to 45. They're 20 to 40. So I remember 30. So I have 60, 30. And then for monocytes, I remember a number in the middle between 2 to 10, which is 6. Eosinophils, I remember the number in the middle, which is 3. So I remember everything by the number in the middle. And then I just assume both ends, okay? So whenever I look at this, so I remember neutrophils as 60, lymphocytes as 30, so 60, 30, and then monocytes as 6, eosinophils as 3. So it's 60, 30, 6, 3. That's how I remember it. 60, 30, 6, 3. And I remember everything with the mnemonic of never let me eat bananas. And basophils, they should be less than 1. That's it. Can you come again, please? How I remember it? I remember it with never for neutrophils, let for lymphocytes, me for monocytes, eat for eosinophils, bananas for basophils. Then I remember a number in the middle within these ranges. So the number in the middle between 40 and 80 is 60. The number at the middle between 20 and 40 is 30. The number in the middle for monocytes here is going to be 6. For eosinophils is going to be 3. So numbers I have are going to be 60, 30, 6, and 3. So 60, 30, remove the zeros, you have 6 and 3, and just finish with a 1. So that's how I remember it. Never let me eat bananas, 60, 30. Remove the zeros, 6, 3, and then you just get a 1. So that's it. That's how I remember the differential for the white blood cells, okay? So that should be more than enough for you if you want to remember these percentages. So again, I'm not going to assume that it's not handy for anyone to remember the normal range for a white blood cell. It's actually very important for your clinical practice, at least, to remember the normal range. Now, what is the difference between the relative range and the absolute range? The relative range means the number is being given as a percentage of the whole. So, for example, if I say that I have 45 people attending my class, so I'm giving the absolute number, okay? The absolute number is 45. Now, if I say that 10% of the third year in MTI is attending my class, then I'm giving you the relative number. So that's like 10%. So it's just a percentage versus the green number, okay? So that's what we mean here. So the white blood cells, again, which just comes in very handy for us to remember. I'm actually glad that you guys are sending me questions today. This is a big improvement. So again, as we said, the white blood cell counts, the range, they go from 4,500 to 11,000. Now we're going to see a lot of different ranges in these slides because ranges are not something that everyone 100% agrees on. However, please just stick to knowing 4,500 to 11,000. This is the most correct number that I've seen being mentioned across different examination boards. Just stick to that, 4,500 to 11,000. This is important. Now, if you have an increased white blood cell count, we'd like to call that leukocytosis. So remember, leuko means white, cyto means cells, and osis means high. So I have like a high white blood cell count if you have white blood cells above 11,000. If it's lower than 4,000, we call that leukopenia. If it's lower than 4,500, it's also leukopenia. That means low blood cells. Okay, so that's about it for the for leukocytosis and leukopenia. So how do we read the differential counts of white blood cells? So as I said, I like to remember them by never let me eat bananas, 60, 30, 6, 3, and 1. So that's how I like to remember the numbers. So as we proceed from here, let's just start looking at different disorders. So here it says, this is just everything written here is just basic. There's nothing here that is that is of importance, but all you need to know here is just the terms. And terms are very important on your exam. So it's going to get you extra marks if you're capable of saying that the patient has or the patient has leukocytosis, rather than saying that the patient has a high number of white blood cells. Leukocytosis gets you better marks than a high number of white blood cells. Leukopenia is much better than low number of white blood cells, because you're a doctor, so you should be able to use these terms very easily. Okay, so as I said, if you have leukopenia, it means that you have a blood or a white blood cell count that's lower than 4,500, and sometimes the actual cause that you have a low number of white blood cells is that you have a low number of one of the main constituents of the white blood cells. So if you have neutropenia, now remember neutropenia, never let me eat my bananas, the N goes with the 60. Now remember the range for that was 40 to 80. Okay, so if neutrophils can form up to 80% of your white blood cells, it only makes sense that if you have very low number of neutrophils, that you're going to have a very low number of leukocytes, because they form around up to 80% of this number. Okay, so low neutrophils, you're going to definitely have leukopenia. Same goes for lymphocytes. Now remember, never let me eat my bananas. The L was the second one, and it goes with the 30. Now with the 30 reminds me that it's 20 to 40, and if it constitutes 40% of the blood, so if you have lymphopenia, you're definitely going to have a low number of white blood cells. Perfect, 30. So again, leukopenia is a general term. It can be because everything within the blood has a low number, or it just can be because one specific type of white blood cell is low. So like neutropenia or lymphopenia in these cases. The term leukocytosis, this means that we have an absolute increase in the white blood cell numbers. And also it can be because everything is high. And sometimes it's just because one cell type is high. So if you have a high number of neutrophils, it's going to be called neutrophilia. And philia means that the blood is in love with neutrophils. So I have a lot of neutrophils. Now remember, they're up to 80%. So if you're saying 90% or more than 80%, so the blood is in love with neutrophils, so many neutrophils in the blood, we call that neutrophilia. Eosinophilia, basophilia, same concept, okay? Lymphocytosis for lymphocytes, monocytosis for monocytes, okay? So that's it. So let's speak a little bit about neutrophil disorders. Now, again, never let me eat bananas. The N with the 60, the range is 40 to 80. So what are neutrophils? Neutrophils are a type of white blood cells, and they play an important role in the immune system's response to infection and inflammation. So as we just as we just discussed, the neutrophils, they form 40 to 80% of the white blood cells. So they are the most abundant type of white blood cells in the body. And their primary function is to engulf and destroy bacteria and any other foreign substance. So what happens is that whenever your body detects an infection or an inflammation, it just starts to release chemical signals that attract the neutrophils to the site of the problem. So neutrophils then migrate from the bloodstream to the infected or inflamed tissue, and then they use a process that we call phagocytosis to engulf and digest the invading pathogens. So neutrophilia is a condition where you have abnormally high number of neutrophils in the blood. And this can happen in many situations. So this can happen in infections, and this makes sense. So neutrophils are activated in infections. So neutrophilia is very common, especially in response to a bacterial infection, because the body is trying to fight off the invading pathogens. So if you just paid attention to how I said the neutrophils behave, as I said, the neutrophils, they engulf and destroy foreign substance. Okay, so bacteria, they do not reside within the RBCs, or they do not reside within the cells. They're outside usually. So it's easy for the neutrophils to go to the site of the inflammation and encounter a bacteria and eat it. But viruses, on the other hand, they're mostly intracellular. Okay, we're talking about intracellular stuff. It's not mostly, they're always intracellular. Excuse my wordings. They're always intracellular. So the neutrophil is not going to eat a cell. So that's why the neutrophils, they're not fighting virals. They're just fighting bacterial infections, okay? And other infections, but not viral. You can see it in inflammation. So neutrophilia can happen even if you have an inflammation that's non-infectious. And we see that a lot in a lot of immune disorders, autoimmune disorders, okay? We can see it with stress. And stress here, we mean acute stress, not the kind of stress that you guys are experiencing right now because you have an exam. No, it's the stress that whenever we say stress in medical terms, we're referencing to surgery, we're referencing to physical trauma, not emotional trauma, okay? So all this can be a cause of a temporary increase in a neutrophil count. It's good for you to know that, because if you're seeing a patient and they're in the OR and they have neutrophilia, you just need to know that this is probably temporary. This makes sense because they just underwent surgery or so on. We can see high neutrophil numbers with some medications. So sometimes when we give patients steroids, they can get neutrophilia as a side effect, especially early on. So early on, we can get neutrophilia with steroids. We can see it in acute blood loss. We can see it in acute hemolysis. These can cause neutrophilia as well. On the other hand, neutropenia, where you have a low count of neutrophils, this is something we see when we have also a variety of regions. So as we can see it in infections, especially viral infections, and because here the neutrophils, they're not really the ones in charge for taking over the viral infections. You can see them in chemotherapy. So whenever we give patients cancer treatments such as chemotherapy, that can result in a temporary decrease in the neutrophil count. Patients have bone marrow disorders. Neutropenia can also be caused by bone marrow disorders because whatever affects the bone marrow's ability to produce white blood cells, such as aplastic anemia, is going to affect the number of neutrophils, okay? So in summary, the neutrophils, they have a very important role in our immune response by engulfing and destroying bacteria and foreign substances. But an increase in neutrophil count or neutrophilia, this usually occurs in a response to a bacterial infection, inflammation, stress, medication, while a decrease like neutropenia, we're going to see that with viral infection, cancer treatments, bone marrow disorder. There's also, we can see a neutropenia with some drugs, like for example, clozapine. This is a medication that we give to resistant psychiatry patients. We can see neutropenia also. We have cyclic neutropenia. Now, cyclic neutropenia is a rare syndrome. This is just patients who get recurrent neutropenia, like usually every 3 weeks. So whenever they have neutropenia, they're going to have fever, they're going to have malaise, they're going to have mucosal ulceration, maybe some abdominal discomfort. However, they only get these symptoms once every 3 weeks, and they're usually well between episodes. Now, this is a very rare disease. I wouldn't really memorize it if I'm trying to remember like a good differential for neutropenia or neutrophilia, okay? So in case of inflammation or infection, okay, guess someone sent me a question. What does cyclic mean again? Cyclic means that the patient, so let's give an example with numbers. So a patient's going to be sick on the 1st of March, okay? So let's say today is the 1st of March, so the patient is sick. Now, when it comes the 2nd of March, the patient is free of symptoms. They don't have any problem. And they're going to be free of these symptoms. They're going to be very normal, just like you and me, assuming that hopefully you're not in any discomfort at this time. So they're going to be very normal from now on till the 21st of March. So they're going to stay normal for 3 weeks. They don't have any problem. And if you take a CBC anytime within these 3 weeks, their neutrophils, they're going to be normal. But if you take a CBC on the 21st, guess what's going to happen? They're going to have neutropenia and they're going to have symptoms. So that's what it means cyclic. They have cycles. So there comes a time where they have low neutrophils, where they have or where they have neutropenia, where they have symptoms. But again, this just stays for a small period of time, and then they go on a longer period of time without any symptoms. It's called cyclic neutropenia. It's quite rare. Okay, so again, so let's go back to the slide. So in a case of inflammation or infection, some immature cells appear in the peripheral blood. Now, I know some of you also saw this and they felt extremely overwhelmed. So what is this? What do they want from us? Well, I'm just going to say this as easy as I can. So what happens is, let's consider a normal case where someone gets an infection, a bacterial infection. So let's say you have a bacterial infection, let's say you have cellulitis, for example, okay, in your leg. So you have cellulitis in your leg, so that's where the bacterial infection is. So your body needs to respond to that by the cells which are capable of engulfing the bacteria. So it needs to send the neutrophils. That makes sense, right? So where are the neutrophils currently residing? In the blood vessels. That's why we see them on the CBC. So they need to leave the blood vessels and go to the bacterial site infection. So if everything is leaving the blood vessels are going to have a very low concentration of neutrophils. So how do we solve that? The bone marrow, the organ that is responsible for creating the neutrophils, is going to start pumping the neutrophils into your peripheral blood vessels, because you still need more neutrophils to fight off this very nasty infection, right? So this is the normal cycle. Now, suppose you have a terrible infection. You have an infection that is very strong. Your body is doing all its best to try to fight it off. So what's going to happen is that you're going to pump out all the neutrophils from your peripheral blood vessel, and your bone marrow is going to create neutrophils and pump them out as fast as it can. But however, you will reach a point where you're exceeding the bone marrow's capacity to create mature neutrophils, right? So now you're requiring too much work from the bone marrow, so it's not capable of giving you the amount of mature neutrophils that you need. So what is the next best thing? What can your bone marrow do now? You need more neutrophils because the infection is still going on. However, the bone marrow cannot supply mature neutrophils. So what is it going to do? It's going to send immature neutrophils. So it's not going to wait for the neutrophils to mature. It's going to send immature neutrophils. So it's going to send them in earlier stages before they become segmented mature neutrophils. That's the band cells, the metamyelocytes, and the myelocytes. Now, do you need to remember these three names? No. All you need to know is that normally a mature neutrophil is a segmented cell. If it's non-segmented, that's an immature neutrophil. Now, we start having immature neutrophils, non-segmented cells, especially remember this word, band cells in the blood. It means that your bone marrow is being forced to pump out the immature neutrophils into the blood because you're having a very nasty infection, okay? What do we call this? We call this a shift to the left, okay? So any questions so far? Everything makes sense? There will be monocytosis at the end of cyclic neutropenia. I'm not an expert on cyclic neutropenia, to be honest. I've always looked at it as a rare disease, nothing more than that. How do you differentiate between an infection, immature cell, or bone marrow disease? I don't understand the question. If you can rephrase it, I'll address it. You can rephrase it, okay? So let's move forward. Now wait for the question to be rephrased after that, after the slide. So here, let's look at this slide. So this is the definition and symptoms of agranulocytosis. So I just want to be precise with my wordings, because I want you guys to be, because it's very important to you guys to pick up on the definitions, okay? So when we say neutropenia, whenever we say neutropenia, we're usually describing like absolute neutrophil counts that are just lower than the lower limit, lower than 1500, okay? 1500 per microliter. So that's what we're saying whenever we see neutropenia. Whenever we say the word agranulocytosis, some people use it when the patient have numbers that are lower than 500. But in fact, whenever it's being said around in a hospital, people mean that the count is lower than 100. That's the more accurate number to think of when you're thinking of agranulocytosis. Now, by now, you should realize that agranulocytosis is not something to be taken lightly. So if we are saying that neutrophils, they form up to 80% of your white blood cell population. It's at 60 at an average, but it's 40 to 80. Now, we said if neutrophils are up to 80%, and we have
1,500 to 7,500 per microliter, cells per microliter. So if a patient has lower than 100, means that they have severe leukopenia, and the main constituent of the white blood cells is almost absent. That's agranulocytosis. So it's not something to be taken lightly, okay? So patients with such very low counts, they experience fever, they have chills, and they're also at a very increased rate for fatal infections. However, some of them may be asymptomatic, and sometimes we just find this on an accidental CBC. So the question was, how do we know whether these cells are present due to infection or bone marrow disease that is not allowing them to mature properly? Well, that if you're thinking the only diseases that would not allow them to mature properly would be leukemias, and we know leukemias by markers of leukemia. So we have other tests to identify whether this is a leukemia or whether we're just looking at a patient who's facing a difficult infection and they have a large number of blasts. Usually, if a patient has an infection, we're going to see a high ESR, a high CRP. They're going to have symptoms of infection. They're going to have a history that goes on with an infection, which is probably way more acute than leukemia. But some leukemias are also acute. So again, the main thing that we're looking at to differentiate between both is going to be the B symptoms of cancer, if we're looking at the history, and is going to be the markers for leukemia if we're looking at investigations. So another question is, doctor, is immature neutrophils, is it considered neutropenia? No, it's not considered neutropenia. If a patient has immature neutrophils, that doesn't mean they have neutropenia. It just means that they have a shift to the left. It means that their body is doing more than its or beyond its capacity, trying to fight off a very nasty infection. Okay. So let's move forward. So again, never let me eat bananas. We discussed the N, the neutrophils. The L is for the lymphocytes. Now remember, we had 60, 30, 60, 1. So lymphocytes, the average is going to be 30, but the range is 20 to 40. So let's shift gears and discuss lymphocyte disorders. Now, lymphocytes, they form our adaptive immune response. They're very important for us as we experience infections to adapt or to form an immune response that is more robust than our original or our innate immune response. Now, they would generally be increased in most infections because, as I said, this is how we fight off an infection through the adaptive immune response. So it's going to be increased in most infections. But I think it goes without saying, I don't need to say that you're going to have a low lymphocytic count if you are experiencing HIV. If you are experiencing human immunodeficiency virus, it goes without saying that you're going to have a low lymphocyte count, okay? And we also might see low lymphocytic counts in chronic lymphocytic leukemia. We're going to see high numbers in chronic lymphocytic leukemia. Excuse me for that. Excuse me for the slip of tongue. So this increase of number of lymphocytic count, that's known as lymphocytosis. So some notable causes of relative lymphocytosis, which means that the patient doesn't really have a high lymphocytic count. It's just that they have a troublesome blood composition that makes the lymphocytes look higher relatively to everything else, but they're not really high. So we see that just if I'm going to remember anything from this list, I'm going to remember connective tissue diseases and thyrotoxicosis. These are the two things that I'm going to remember for relative lymphocytosis, okay? This is not a pediatrics exam, so I wouldn't remember age less than 2 years. So how do we approach lymphocytosis? Well, we need to check the patient's history. So if a patient has lymphocytosis, we need to check if the patient has a chronic infection. So if they have a chronic infection, you're going to treat the cause. If they have a viral infection, you're going to consult hematology. But is your consultation urgent or is it just a regular consultation? Now, the consultation is urgent if you're seeing signs that are pointing towards a serious lymphoma or a serious leukemia, okay? So what's giving us or hinting us towards that this patient might have a hematological malignancy? Well, sometimes the patients might have significantly raised, might have unexplained weight loss, which is a common thing. most cancers might have these symptoms like night sweats and fever. The patient is undergoing or they have lymphomas. You might start seeing lymphadenopathy, hepatomegaly, splenomegaly. Sometimes also should be very concerned if the patient's bleeding profusely or they have easy bruising, okay? So if you see any of these red flags, you have to consult hematology urgently. If you don't see any of them, all you have to do, and you know that the patient has a viral infection, all you need to do in this case is just need to follow up in 6 weeks. Now, I know some of you might be confused, like if the patient doesn't have a viral infection and they have lymphocytosis, should I jump into thinking that they have cancer? No. If they have any of these signs, this is when you get to send an urgent hematology referral. Otherwise, there are other steps that you should go to before you send an urgent hematology referral. Okay. For the viral infection, if the patient has a viral infection, all you need to do is just wait for 6 weeks. If they still have lymphocytosis, send them to hematology, okay? So in this slide, we're going to discuss the causes of lymphocytopenia. So lymphocytopenia is a condition where you have a decreased number of lymphocytes in the blood. Now, lymphocytes are a type of white blood cells that play a crucial role in the immune response to infection and disease, okay? So lymphocytopenia, this can cause for various factors. So this can happen in like HIV and AIDS, for example, okay? So this is the human immunodeficiency virus, HIV, and this attacks and destroys the CD4 positive T cells. And this is a type of lymphocytes. And because they attack these types of lymphocytes, it starts to weaken the immune system, and this increases the risk of infection. So HIV and AIDS are one of the most common causes of lymphocytopenia, and you just always need to ask about the patient's sexual history if you see lymphocytopenia, okay? Especially if the CD4 plus T cell counts are low. Now, you should also check if the patient has a lymphoma. So a lymphoma is a type of cancer. This affects the lymphatic system. So, and remember, the lymphatic system is where your lymphocytes normally reside. So lymphoma can cause a decrease in the lymphocyte counts, especially in advanced stages of a lymphoma, okay? Now, steroids, they can also cause patients to have lymphocytopenia. Now, long use of steroids, especially if you're giving a patient prednisone, this can suppress the immune response and decrease the number of lymphocytes in the blood. Chemotherapy, cancer treatments can also suppress the immune system and decrease the lymphocytic counts. UV radiation, so if you're exposed to UV light, especially maybe if you're taking a tan, you're exposed to the sun very long because of the nature of your work or where you live. People who like to use tanning beds, all that just could make them get unnecessary exposure to UV radiation. And UV radiation can damage your lymphocytes and decrease the number of lymphocytes in your blood. You can see them in myasthenia or like myasthenia gravis. Myasthenia gravis is an autoimmune disorder that affects the neuromuscular junction. So this is something that you'll study in neurology and leads to muscle weakness and fatigue. These patients can also have a decreased number of lymphocytes. Autoimmune disorders such as lupus, rheumatoid arthritis, these can cause the immune system to attack and destroy lymphocytes. So we can start seeing lymphocytopenia. If patients have protein malnutrition, so they have severe protein malnutrition, like maybe a patient has anorexia nervosa, maybe a patient is in a case of starvation, then we can start to see a decrease in the number of lymphocytes in the body because it makes sense. The body lacks the necessary nutrients to produce new cells, okay? So that's about it for lymphocytopenia, lymphocytosis. So as we said, never let me eat bananas. So we discussed the neutrophils, we discussed the lymphocytes. Now we're going to discuss the monocytes, okay? So here we're discussing monocytosis. So monocytosis, this is a type of we're discussing monocytes, and monocytes is just a white blood cell that has a very important role in the immune system. It works against infection and inflammation. Now, in terms of size, not in terms of number, but in terms of size, they are the largest type of white blood cell. Okay, and they have this kidney-shaped nucleus, which makes it easy to identify a monocyte. So monocyte, they're produced in the bone marrow, and then they're released into the bone stream where they circulate, and then they migrate into the tissues. When they migrate into the tissues, they can start differentiating into macrophages or dendritic cells, okay? So most of you know macrophages. Macrophages are these cells that engulf and destroy foreign substances. they eat dead cells, they eat cellular debris. Okay, so monocytosis is a condition, or what we need to discuss here is monocytosis, and this is a condition where we have an abnormally high number of monocytes in the blood. So this can happen in many reasons. So maybe an infection, because maybe, as we said, monocytes, they differentiate into macrophages and they differentiate into dendritic cells, which serve to fight against bacterial infection. They also have an important role in many viral infections. So we can see them high in both. We can see them high in inflammation. Can happen, especially people have a chronic inflammation, like people have autoimmune disorders like rheumatoid arthritis or inflammatory bowel disease. Now, some cancers, such as leukemia, lymphoma, they can also cause monocytosis. We can see them in some medications, also like corticosteroids, prednisone, and so on. They can cause monocytosis. We can see it in some conditions like tuberculosis, TB, sarcoidosis. Maybe I've seen it come up with some cases with Kawasaki disease, but that's more for the pediatric population. Also, we can see it with Hodgkin. You can see it with chronic myelomonocytic leukemia. I would always remember any cancerous cause for any condition, because, well, I don't know, the question, people who make questions, they always like to put a scenario where a patient has a certain type of cancer. So cancers are always important for you to remember if you're trying to memorize a list of causes, okay? Followed by that is, as we said, never let me eat is the eosinophils, and eosinophils, never let me eat bananas, 60-30, 6-3, so the average number for is 3, the range is 0 to 5%, and perfect. Thank you. So perfect. Now, as we said, eosinophilia here, the patients, they have a large number of eosinophils. Now, the main thing that I want you to keep in mind is that eosinophils, they're usually high with patients who have allergies, in atopic diseases. Now, atopic diseases, they're also allergies. So you can see that in asthma, you can see it in eczema, and also we see eosinophils, higher eosinophils. You can see eosinophilia in parasitic infections. So if you only remember that eosinophils are high with allergies and parasitic infections, that's actually more than enough. You don't need to know more than that. Now, there's a case here, or like just because I know some of you are gonna try to remember this mnemonic allergies, and they're gonna come across everything written here. So I know that this is the one that you're probably gonna be confused about, is eosinophilia myalgia syndrome. Now, eosinophilia myalgia syndrome, this is just a condition that affects your muscles, skins, and lungs, and you have eosinophilia. That's basically what it is. So you have like affection of muscles, skin, and lungs, and you have eosinophilia as well. That's it. Now, the bananas, the basophils. So, okay, the basophils, usually they shouldn't exceed 1%. If they're exceeding 1%, probably have basophilia. So basophils, they're a type of white blood cells, and they're important for allergic reactions and parasitic infections. They're very similar to the eosinophils in that certain point. They're the least common in terms of number, and they're basophils, so they stay in dark because we already explained where the name comes from. So what do they do? The primary function for basophils is to secrete chemical mediators. Most famous ones are histamine and heparin, and they do that in response to allergens and some parasites, okay? So what's the main function? So they function mainly in allergic, or in allergies, allergic reactions. They're involved in immediate hypersensitivity. And they're one of the main causes why the blood vessels dilate in hypersensitivity, and we start to see redness and itching and swelling. They're important to fight off parasitic infections. Now, when do we see basophilia? We will see that in allergic conditions. We're going to see basophilia. That's the most important thing to remember. We're going to see basophilia in polycythemia vera. Now, polycythemia vera, this is a bone marrow disorder where your bone marrow actually goes bananas. It goes crazy. All it does is just it starts overproducing everything. Everything is being produced in extreme excess. So we have very thick blood. That's polycythemia vera. And basophilia is also going to be present in that situation, okay? We can say it in cancers like chronic myelocytic leukemia, maybe lymphomas, non-Hodgkin. These are the main causes where you can see basophilia, okay? So I wouldn't remember everything here because you're not gonna diagnose a patient who has myelodysplastic syndrome because they have basophilia. That's not the proper way of diagnosing that. If I ever met a doctor who correctly, I'm not gonna say even incorrectly, I'm gonna say correctly diagnose the patient with myelodysplastic syndrome because they have basophilia, I'm never gonna respect them, even if they correctly did that, because that's not the right way to go. There's so many questions that need to be answered before you arrive to a conclusion, okay? So learning this exhaustive list, this is not how you're gonna diagnose an exam. So don't overwhelm yourself with this. Just all you need to know is what a basophil does. Just know what are the main conditions where you can see basophilia. And I told you, you're gonna see that more in allergic reactions and parasitic infections, just like eosinophils. You don't need to know everything here. If you just want to do more, slightly more, just for the sake of being more prepared for your exam, just remember polycythemia vera, and remember the Hodgkin, non-Hodgkin, the leukemias, everything that falls within being cancers. Okay, that's what you need to know. Okay. So before we proceed, I think we discussed everything that is related to the white blood cell differential. So can you guys tell me if you have any questions before we move on to discussing blood or discussing RBCs? So any questions so far? Everyone comfortable with what we discussed? Okay. Okay. Here. Okay. So let's move on. Now we're going to discuss the RBCs. So just gonna maybe lay out some terms before we start going into discussing how to read or how to interpret the RBCs on a CBC. So hemoglobin, everyone knows what hemoglobin is. Hemoglobin carries oxygen within the RBCs. So the number that's given next to hemoglobin on the CBC just reflects the oxygen carrying capacity of the red blood cells. Okay. If you have decreased hemoglobin, the patient has anemia. They have increased hemoglobin, the patient has polycythemia. Poly means many, cy means cells, and emia means in the blood. They have many cells in the blood. That's when you have a lot of hemoglobin. If you have many RBCs, you're going to have a lot of hemoglobin. Okay. So it's either anemia, polycythemia, and hemoglobin, as we said, just is a good way to know whether the patient has anemia or not. Followed by that is hematocrit. Hematocrit is just the percentage of the blood volume. So both colors, the red and the yellow within this image, this is the blood volume. This is the entirety of the blood inside the tube. So the percentage of this, which is red, the percentage of this, which is formed of RBCs, this is what we term as hematocrit, okay? So the percentage of blood volume, which is made of RBCs. So this is the blood volume, this is the red part. If this red part is 70% of the blood volume, then the hematocrit is going to be 70%. Here, this is the entirety of the blood. If this is 30%, then we're going to say that the hematocrit is 30%. Here as well, if this is 45%, we're going to say it's 45% of the blood volume, which is the hematocrit. PCV is just another way to say hematocrit. It's just it stands for packed cell volume. Okay, packed cell volume. That's what PCV is. And it's just a measure of the proportion of blood that is made up of cells. Okay. Followed by that, we need to know the reticulocytes. So reticulocytes are immature RBCs, and it just gives us an idea about the bone marrow's activity. So if the bone marrow is overactive, it means that you're probably bleeding, it means that the patient is probably losing blood. So the bone marrow has to be hyperactive to generate more RBCs. Now, if it falls into the position where the requirement or the RBC's requirement is much more beyond the bone marrow's capacity, is going to do the same thing that we discussed before, which is that it's going to start pumping out immature RBCs. So whenever we look at a CBC and we start seeing reticulocytes or immature RBCs, this is giving us an idea of the bone marrow activity. If we see a lot of reticulocytes, it means that this patient's bone marrow is overworked. It means that this patient is probably trying to compensate for something, okay? So it says here, increased reticulocytes, this is what we call as polychromasia. And this means that the bone marrow is hyperactive, is trying to compensate for something, and usually that is RBC loss, whether the patient is bleeding or they have hemolysis or so on, okay? So how do we look at the RBC counts, or how do we look at the RBCs on a complete blood count? So these numbers are quite very important. So I would try to remember them. I wouldn't remember them in 4.2 or 5.8. I would just remember 4 to 6 and 4 to 5.2. That's what I would do. So it's going to be very useful for you. Okay, so males just remember 4 to 6. Females remember 4 to 2, 4 to 5.2. Now, for these cases, or for because I know a lot of people would just always look at this and be confused, like, why is it that females have a lower RBC count than males? Why is it that females have a lower hemoglobin concentration than males? And I've heard a lot of wrong explanations in my day. I've heard a lot of people who would say stuff like, oh, because females, they have their menstrual periods and this causes blood loss. Well, it's not that much blood, and if that made sense, it would have made sense for post-menstrual women to have the same RBC count and hemoglobin concentration as men, but that's not true. What is true is that estrogen and testosterone, they have different effects on erythropoietin, especially in the kidney, and just testosterone is just a more potent effector of EPO, of erythropoietin. So that's why men usually have higher hemoglobin than women. You're right. Someone told me they have no androgen, right? So that's it. So again, is increased RBC count also called polycythemia? Yes. Yes. If you see a high RBC count, that's polycythemia. Perfect. So, as I said, just remember these numbers. Remember the hemoglobin counts. Males are from 13 to 17.5. Females are 11.5 to 15.5. Now, I would not remember the hematocrit. Why? Because if I want to, here's what I do. I never, for the entirety of my life, I never memorize the hematocrit numbers. And the reason is, if you divide the hematocrit by 3, it's going to give you the hemoglobin concentration. So for a male who has a hemoglobin concentration of 13 multiplied by 3, that's 39. And you're going to see that the hematocrit is going to be 39. It's very unusual for a patient to have a discord between those numbers. And if they have a discord, it's not going to be exceeding 1%. So just remember this. And if you want to know, if you're not given a hemoglobin concentration, if you're not given an RBC count, and you're just only given a hematocrit, all you need to do is just divide this number by 3 and see if it falls within the normal range of hemoglobin. That's what you need to do. Okay. And then followed by that, so this is the normal procedure whenever we look at the CBCs. We look at the RBC count, followed by the hemoglobin, then the hematocrit, then we start looking at some indices. What are these indices? What is the important ranges that we should know of all patho, all CBC ranges? What about TS? Okay, I'm going to answer that question at the end. Can you keep it for the end? And I'm going to answer that question in the end. Okay. So what are the indices that we need to look at? So we start looking at the mean corpuscular volume, the mean corpuscular hemoglobin, the mean corpuscular hemoglobin concentration, and the red cell distribution method. Okay, so I think the other slide here just goes over. Yeah, so this, you don't need to know how anything is calculated. Just for to make this clear, you don't need to know how anything is calculated. And all you need to know from here is the numbers. Okay, and if you want to know one number for your exam, you just need to know the mean corpuscular volume, that it ranges from 80 to 100, not 76 to 95. This number is too complex for no reason. Just 80 to 100. That's what you need to know for the mean corpuscular volume. Okay, now everything else, I'm more than definite that they're going to put it in your exam. I'm pretty sure they don't require you to know 27 to 34. They don't require you to know 32, 39. I don't think this is going to be an issue of any sort whenever whenever you're going to be in your exam. Okay, but you need to remember the percentages for the lymphocytes. That's going to be helpful. You need to remember that leukocyte counts should range from 4,500 to 11,000. That is helpful. I would remember the normal ranges for blood in patients. Now I would remember what the normal for a male is, what the normal for a female is. I remember the normal and remember the normal hemoglobin concentration for both. That will work. That will work well for your exam. I think they're going to give it to you. Like, I don't think you're also going to remember these numbers. I doubt it. I'm just going to confirm with the department, but I highly think they're going to give you these numbers also on an exam. Okay. So
let's go into the mean corpuscular volume. So, okay, before we move into the mean corpuscular volume, I think we just arrived to finish the first half, which is the tougher half of the lecture.
Okay. So let's proceed from where we stopped last time. So you don't need to know any of these indices or how any of these indices are calculated. Just need to know what they mean. So mean corpuscular volume, this is the average measurement of a single RBC. Okay. So let's say, for example, we're a class of 10 people, and this class of 10 people has 5 people who are maybe measuring 170. We have 5 people who are measuring 190. So we're going to say that the average height of this class is 180. Okay. Same goes with RBCs. We're going to take a picture of the RBCs. We're going to have RBCs which are higher than average. We're going to have RBCs which are lower than average, but we're going to take an average number. And this average number, if it falls between the normal average number for the entire population, which is 80 to 100, we're going to say that this patient is normocytic. Okay, we're going to say this patient is normocytic. So normocytic, the word normal comes from normal. Cytic means cells, so they have normal cells. Why did we call them normal? Because their volume is normal. So this is normocytic. If they have RBCs, or the average volume of these RBCs falls below range, so it's less than 80, we're going to say that these patients have microcytic. Micro means small, cytic cells, so they have small cells. If it's above 100, we're going to say they have macrocytic, so they have large cells. Okay, so it's macrocytic, normocytic, microcytic. That's what we're looking at the MCV. Followed by that, we look at the mean hemoglobin volume. So what's the average amount of hemoglobin carried by a single RBC? Now, all of you know by intuition that RBCs are red. Everyone knows that. They're called red blood cells. So they're definitely red. And most of you know that they are red because they carry hemoglobin, because hemoglobin is red. Okay. So if a patient has low hemoglobin in every RBC, it means that their RBCs are going to be pale red. Okay. They have normal amount of hemoglobin, their RBCs are going to be normal red. They have low amount, this is going to be pale red. Okay. So this is why we would say a patient has hypochromic anemia. So hypo means low, chromic means color. The word chromic means color. That's why whenever people who work in the cinema industry, they call the green screen that they use, they call it the chroma. The word chroma means color. Okay, so hypochromic means low on color. So if a patient has low hemoglobin, the RBCs are pale, they're low on color. So that's why we say they have hypochromia. So a patient might have an MCV that is lower than 80. What would we call a patient who has an MCV that's lower than 80? Can someone tell me? MCV lower than 80. What would we call that patient?
Microcytic.
Microcytic. Perfect. Now, if they have a low hemoglobin, if the hemoglobin now is low, if it's lower than 27, what we call it?
Hypochromic.
Hypochromic. Perfect. So if they have both, if they have a low MCV and a low mean corpuscular hemoglobin, what we call that patient?
Microcytic hypochromic.
Perfect. That's what you need to do on your exam. So if you're capable to arriving to a conclusion that this patient has a microcytic hypochromic anemia, that's all you need for your exam. Whenever you're looking at the CBC, okay? Whenever you're looking at the blood, especially. That's it. That's all you need to do. So let's say the patient has an MCV that is beyond 100. So I have an MCV of 105. What will you call that patient?
Macrocytic hyperchromic.
Perfect. So that's it. That's what you guys need to do. Okay. Then we look at the mean hemoglobin concentration. So the average concentration of hemoglobin per unit volume of RBCs. Just know this number. This appears on your exam. It's only going to be 32 to 39. That's it. If it's lower, you're gonna say that the MCHC is low. If it's high, you're gonna say the MCHC is high. That's all you need to know. Okay. Let's proceed. So again, this is here just saying the same things we just said. So it says, how do you calculate the mean corpuscular volume? You don't need to know that. You just don't need to know it. You just need to know that the normal range is 80 to 100. If it's lower, it's microcytic. If it's 80 to 100, it's normocytic. If it's higher, it's macrocytic. That's it. And then you start looking at the mean corpuscular hemoglobin. That's what gives everything color. So if you have a low hemoglobin, then the patient's going to have pale RBCs, so they're going to be hypochromic. Okay, if they have normal hemoglobin, they're going to be normochromic. If they have more than 34, they're going to be hyperchromic. Okay, that's it. That's all you need to know. And then followed by that, we need to know the MCHC, the mean hemoglobin concentration, and the RDW, the red cell distribution width. So the red cell distribution width is just RBCs vary in width. Okay, that's it. Okay. So RBCs vary in width. Okay, so the variation can range between 10 to 15%. So in case an RDW is elevated, this is called anisocytosis. What does that mean? What is it, the variation in width? So normally, let's say that a normal RDW would mean that I'm going to give you any numbers. The numbers I'm going to give you right now are not accurate, okay? So let's say, for example, that RBCs, for a single patient, they range from, their width ranges from 100 to 115, okay? So 100 to 115, the smallest one is 100 at width, and the largest one is 115 at width. So the range is going to be 15%. So the smallest one is 100, largest one 115, the range is 15. So that's the normal range. If the smallest one is 80 and the largest one is 120, we have a 40 difference. We have a range that is higher than 30%. So that means that something is screwed up with the RDW, okay? So if you have an elevated RDW, it means that we have too much variation in the width of the RBC. We have so many different shapes of RBCs in the blood. We call that anisocytosis. So if we have RDWs elevated, we call that anisocytosis, okay? Means that there's a lot of variation in RBC morphology. This can be useful if we're trying to distinguish whether the RBC defect is acquired or is it just hereditary, okay? Now, you don't need to know this. You guys don't need to know this slide, because for you to know this slide, you need to know everything about each and every disease that will cause any of these shapes. So it makes no sense for you guys to just stick to this and memorize this. It's not going to appear on a slide in your exam and ask you, oh, what is this? No, that makes no sense, okay? So just use this to know that this is the normal cell. If it's smaller, it's a microcyte. If it's larger, it's a macrocyte. This is oval. Why is this slide in our course? I can tell you why, but after the lecture. Okay, so he said this patient has a hypochromic, means it has low on color. So just showing us why hypochromia is just going low, just giving you a good idea. Okay, so just don't need to memorize this. This is going to waste your time for no reason. Now, this is just a summary of how RBCs are interpreted. So I know a lot of you are very confused by this. A lot of you think that they need to memorize everything about this slide. You don't, just really don't. All you need to do is remember the sequence. So if a patient has anemia, how do we know that they have anemia? That's the first question when we look at the CBC. Does the patient have anemia? So how do we... Perfect. Hemoglobin. I like the enthusiasm. Thank you. So if a patient has low hemoglobin, or if they have a low hematocrit, or if they have a low RBC count, then we're going to suspect, oh, this patient has anemia. So we're going to ask ourselves, is it microcytic anemia? Is it macrocytic anemia? Is it normocytic anemia? So then we start looking at the MCV. If the MCV is low, that's microcytic. If it's normal, that is normocytic. If it's high, that's macrocytic. That's very normal up until now. And then we start looking after that at the reticulocyte count. So start looking at the reticulocyte count is low or the reticulocyte count is high for each and every of them. Now you don't need to memorize this. No, that doesn't make sense. You don't need to memorize this for your exam. You will need to know this after you've studied the hematology course in the 4th year, not for the investigation. This makes no sense, because even people who work in clinical pathology, they don't have to diagnose. The hematologist is supposed to diagnose. So now you're thinking, as a clinical pathologist, this isn't your role to send in your diagnosis fully, okay? So what we look at here, the MCV is low, for example, for a patient who has anemia, and then the reticulocytes, that's the thing that we look after. Just know if a patient has microcytic anemia, you need to know that you have to do iron studies. That's it. You just need to know. Patient has microcytic anemia, remember that you need to do iron studies. That's enough for you to know. If a patient has a high MCV, okay, high, I don't know why it's written MVC, it's MCV. If they have an MCV, then you should start thinking of causes of a megaloblastic anemia. So that's why you need to know, we need to check the patient's folate, their B212 level, and you could also know that you might do a bone marrow aspirate. That's something else that maybe I think you guys should know as well. The patient has normocytic anemia, means their blood range falls between 80 to 100, the mean corpuscular volume. It just serves you well to know that you should do maybe G6PD and other enzyme assays. That's it. Just know one or two things from the bottom list. You don't need to memorize anything here. This isn't how the exam is formulated. This isn't how the course is designed. So this isn't even one of the course objectives for you guys to memorize this. You're supposed to memorize this in the hematology course next year, okay? So let's look at reticulocyte counts now, and what do they mean? So again, as I said, the reticulocyte count gives us an image of the activity of the bone marrow. So if you have decreased production of the bone marrow, it means that reticulocytes are low. If the reticulocytes are lower than 2, it means that your bone marrow isn't producing RBCs as fast as it should. Now, why isn't your bone marrow working? Maybe your bone marrow is not working because you don't have enough raw materials, you don't have so you have nutritional deficiencies. Sometimes that would happen with chronic diseases, and sometimes patients have a problem with their bone marrow, so called bone marrow failure. Now, if you have increased reticulocytes, it means your bone marrow is overworked. This means that you're losing blood, and maybe you're losing blood to the environment, so you have chronic blood loss. Maybe you have just hemolytic anemia, where you're breaking off your RBCs within your body, okay? Followed by that are the platelets. Now we discussed the RBCs and the white blood cells. We're going to discuss the platelets. So this is the normal range of platelets. You're definitely going to be given a normal range of platelets on your exam, but know that they fall from 150,000 to 400,000. Now, if you have low number of platelets, that's thrombocytopenia. So now remember, the platelets are also called thrombocytes because they cause thrombosis. So thrombocytopenia, it means literally translates into that the cells that cause thrombocytes or the cells that cause thrombocytosis are low. That's what it means. Cyto, cells, thrombocytosis, penia, low. So the cells that cause thrombosis are low. That's what thrombocytopenia means. So what will cause thrombocytopenia? Patients who have splenomegaly, especially if they have hypersplenism. Now, the spleen serves to kill off the older RBCs and the older blood cells. Now, if you have splenomegaly, hypersplenism, you're going to kill off a lot of the cells within your blood, and you're going to consume your platelets. So that's why you're going to have lower platelet counts in your CBC. If a patient has bone marrow suppression, it makes sense that they're not going to be producing platelets. Some drugs are going to cause thrombocytopenia. Sometimes it's immune mediated, where your body attacks the platelets. You can have thrombocytosis in cases such as anemia, a patient who has underwent a splenectomy and some sorts of inflammation. These are cases where you might see thrombocytosis. Okay, now let's speak about the ESR. But before we speak about the ESR, now that we're done with the CBC, does anyone have any questions about the CBC in terms of the 3 lineages of blood, the white blood cells, the RBCs, and the platelets? Any questions?
Doctor, the patient, if he have a low MCV and normal MCH, what's the diagnosis?
It's gonna be microcytic pneumochronic.
Okay. Thank you, doctor.
Thank you. Okay. So so the question is, will they provide us with enough time for CBC slides? I don't know. I honestly don't know, but the department has the habit of giving people more than enough time on exams. So hopefully, inshallah, everything's going to go well. Okay. So let's talk a little bit about ESR. So the ESR is a non-specific marker of inflammation. Honestly, it's the most useless test that you're ever going to use. I've never seen anything as useless as an ESR. It just gives you absolutely nothing, no information. So ESR is just a non-specific marker of inflammation. It just tells you that there's an inflammation in the body, but it doesn't give you any idea where the inflammation is. It doesn't give you any idea whether this is recent or has been going on for a long time. So many physicians really dislike the ESR. It's just not even as frequently used as it used to be, because we have so many other specific and sensitive tests that can just give us a better idea on what's going on. But we're going to have to discuss it. So ESR, what is ESR? It's erythrocyte. Erythrocyte means RBCs. So erythrocyte sedimentation rate. Now, sedimentation means that if you put the blood in a tube, or you leave the blood in a tube for a long time, how long does it take for the RBCs to stop circulating in the blood and fall by the force of gravity to the bottom of the tube? Okay, so the time for the RBCs to sediment, the times for the RBCs to fall to the bottom of the tube, that is what we call the erythrocyte sedimentation rate. And we look at it at a period of 1 hour. So if after 1 hour, we see that patients have 100 millimeters of RBCs precipitated every hour, then this is an ESR of 100. That's what we mean by ESR. Okay, so again, concerning the erythrocyte sedimentation rate, so as I said, it's a very useless test. It's not going to appear on your exam for you to do anything other than identify whether the ESR is high or low. That's it. What does it do? It tells you there's an inflammation. Does it give you any idea whether it's acute or has been going on for a long time? No, it doesn't. Does it give you any idea where the problem is? No, it doesn't. Is it even fast? Like, would it tell you that a patient has inflammation on the day they started having an inflammation? No, this starts like 24 to 48 hours after acute inflammation. So it's not really that good of a test. It's really not that good of a test. All you should know about it, if patient has an ESR that's more than 100, then this is just giving us that a very good hint that something is very troublesome with the patient. Okay. And again, it just says, as you can see, even with 90% probability, it's not even accurate with that. Okay. So what controls the ESR? So ESR, as we said, if you leave the blood inside a tube for an hour, and then the blood cells start to sediment, they start to fall, they start to precipitate at the bottom of the tube. We're going to measure that in millimeters. Okay. So if it's 7 millimeters, if it's 3 millimeters, whatever, everyone has a normal range. This is the ESR. So what controls it? So it says there are some factors which are pro-sedimentation, which are pushing the RBCs to sediment or to precipitate, such as fibrinogen. And there are other factors which are pushing the blood from sedimentation, and that is the negative charge of erythrocytes. Erythrocytes are negatively charged. Okay, so that's about it for the ESR. Now the normal ranges: males are they have an ESR of 3 millimeters per hour. Females have an ESR of 7 millimeters per hour. Okay. So what's the clinical applications of ESR? It's non-specific. It's just prognostic. It doesn't really help you with any diagnosis, and you have to have everything else with an ESR. It really doesn't have any much added value, I'm going to be honest. So here it just tells you what causes an increase in ESR: inflammation, pregnancy, anemia, autoimmune disorders, infections, any kidney disease, some cancers. They would be decreased in polycythemia. Now, this is what I want you to remember, where the ESR would be decreased, not why it would be increased. We just want you to remember that it would be decreased in polycythemia and hyperviscosity. So if you have a lot of RBCs, then you have a lot of negative charge, then you won't have much precipitation. Okay, so polycythemia, hyperviscosity, these are the two main things I want you to remember. Hyperviscosity, polycythemia, these can cause ESR. You're not going to diagnose a patient with polycythemia and hyperviscosity if they have a low ESR. You're not going to use this to diagnose anything. This is useless. It's not used for any diagnosis. Okay. Why sickle cell anemia decreases? I don't know. I really don't know. I don't think anyone actually uses this test to diagnose anything. So I don't really know that much about the physics beyond it. So I can't really tell you. I'm going to be honest. Okay. So what would cause a moderate elevation in ESR can be infection, inflammation, anemias, pregnancy. Now, a very high ESR, one that's beyond 100, this should let you suspect that something is terribly wrong with the patient. We can see that mostly in multiple myelomas, malignancies. Multiple myelomas are malignancies. Can I ask Mahmoud not to annotate? Thank you. Okay. And okay. Okay, just 1 second. Okay. After that, we're going to speak a little bit about CRPs or C-reactive proteins. Now, these actually have some function. These can actually give you a little bit of an idea about something happening in the human body. Now, the CRPs or the C-reactive proteins, these are proteins that are produced by the liver in response to inflammation in the body. Now, it belongs to a family that we call the acute phase proteins. These are a group of proteins that would increase their concentration in the blood in response to an inflammation or an infection. So CRP is one of the most commonly measured acute phase proteins, and we use it as a marker for inflammation, usually in clinical practice. Now, CRPs, they rise very quickly in response to tissue injury, infection, and other inflammatory process, so they're much better than ESR. The level of CRP can tell us the progress of diseases such as rheumatoid arthritis, lupus, maybe inflammatory bowel diseases. And we can use them to diagnose, bacterial infections, maybe sepsis, even some cardiovascular disease. So, as I said, the CRP, the main edge that the CRP has above the ESR is that it forms much more quickly, and it doesn't last that long in the blood. So it gives us a very good idea whether the patient has an acute inflammation or not, which is not what the ESR does. So at least it's useful to tell us if the patient has acute inflammation or not, okay? So that's the main function of the CRP. So this is telling you that the ESR normally should be 3 in men, 7 in women. CRP should be less than 1. The ESR is just how your body how long does it take your RBCs to sediment. The CRP is just something your liver produces in acute inflammation, and this is a reaction to dead or dying cells in acute inflammation. Okay. So CRP gives you an idea that there's an active inflammation and that something happened within the last day. ESR could have happened within the last several of days, so it doesn't really give you that much of an idea. Okay. So that's about it for everything. All we have to do left is just look at some questions, some CBCs, and see if anyone is capable of interpreting what we see. Okay. So before I proceed, does anyone have any questions so far? Because I think that's about it for explaining. We're gonna do some practice. Everyone okay? Okay. Okay. So let's proceed. So this here asks, what does this CBC demonstrate? Doctor, can you explain how to interpret an iron profile? I can do that, but it's not required. You don't have to know how to interpret an iron profile. It's not part of the curriculum. You can do that on a separate occasion. I don't mind, but it's not required on this lecture.
But the doctors, they revised it with us in the practical revision. So I guess we are required.
No, we're not. It's not part of your, I'll ask again, but it's not part of the original slides. I'll ask, maybe someone just wanted to do that as an extra, but you're not required to differentiate, because if you know how to look at an iron profile, then it means that you have to reach a diagnosis. You're not required to reach a diagnosis. So that's probably why I know that you won't have to do it. I'll get in touch. If they do, I'm going to send you a supplemental video for this on on how to interpret iron profiles. So I don't mind, but I'll just check because it's not even part of the slides. So what am I going to use to explain this? I'll get back to you with this. Okay.
Okay.
Okay. So what does this CBC demonstrate? Now, let's look at this. So Can anyone tell me, while you're looking at this, is this the normal range of RBCs? Does anyone actually know what the normal range of RBCs? Someone says, how about pancytopenia, bicytopenia? Was it studied by the main lecture with the main PDFs? No, it's not. You're not going to be asked about anything that is not in the lectures. No, don't worry. No one is going to say we said this in the lectures. I mean, and they should know it anyhow. Okay, it's not going to happen. No. Okay, where did we stop? So again, so the normal range usually, if we're looking at males, it should be from 4.2 to 5.8. Okay, that is the normal range. It's 4.2 to 5.8 for males. It's 3.8 to 5.2 for females. Okay, so I don't see an issue here. The issue isn't here in the RBC numbers, even though it says here L. But I don't think that this isn't low. This still falls within the range, but it's in the lower part of the range. That's 4.28, and the lower range is 4.2 for males. And it doesn't say whether this is a male or a female, so it's difficult to actually tell. But the hemoglobin, it's 9.7. So this is very evident that this patient has anemia, right? The hemoglobin is 9.7. Now 9.7 times 3, that gives me the hematocrit, which is 29.9. Okay, so if you think this is 30, for example, divided by 3 is 10. Gives you hemoglobin, and this is going to give us an idea of the that this patient has anemia. Now we move on. We look at the MCV, and the MCV should range from 80 to 100. This patient has a lower MCV, so this is 69.7. So this patient has microcytic, and then we start looking at the MCH. Now the MCH here is also low. Was 27 to 34, so this is 22.6, and it says here L. It's telling you that it's low. Okay, this patient has microcytic hypochromic anemia. Okay, so that's it. And now the RDW is high, so you can say the patient has anisocytosis. And you should mention that the MCHC is also low. Okay, so that's what you need to mention. Now platelets are normal. They range from 150 to 450, so that's normal. Okay, so let's look at this. Now, can someone tell me what is wrong with this? Is high, it indicates hereditary cause not acquired.
Leukocytosis, there's leukocytosis. RPC is low, so there's anemia, but MCV is high, so it's probably macrocytic, and MCH is high, so it's hyperchromic. The RDW is also high, so there's anisocytosis. I don't know. So there, I know nothing else.
That's good. Bravo. That's good. That's what we were looking for. So as we said, the RBCs here are low. So the RBCs normally they should range from 4.2 to 5.8. If we're looking at males, if we're looking at females, it should range from 3.8 to 5.2. Now it doesn't tell us whether this is a male or a female, but obviously this is lower than anything. So 2.69, that's very low. Hemoglobin's at 10.6. If someone has the mic open, can they please turn it off? Okay. Okay. Thank you. Ahmad Hussein, can you please turn out the mic? So again, so as we said here, now we can look at the hemoglobin. The hemoglobin is at 10.6. Now, the hemoglobin in the normal range is 13 to 17 for males, 11.5 to 15.5 for females. Now, this is definitely low, and it says here that it's low. Hematocrit is 31.6. Now, the hematocrit, just need to remember the normal range for hemoglobin. So if the normal range here, hemoglobin is low. So we have the info that we're actually required to find from these three inserts, which is that this patient has anemia. Now, which type of anemia is it? We have 80 to 100. This is higher than 100, so it's macrocytic. Perfect. Now, the MCH, that is higher. Now, we know it's 27 to 34. This is 39, so this is high. Now, nothing to say about the MCHC, nothing to say about the RDW. It should range up to 15%, so this is normal. Platelets here, 578. Platelets, I think, are high. And then that's about it. Okay. So let's move forward. So again, this is giving us, can someone, so the first one here is telling me the white blood cells. You can all tell me via the chat box. White blood cells, high or low? So it's 17.8.
telling you that the reference range is 5 to 17. 5 to 17. This is 17.8. So what do you think? So it's high. So what do we call it when a patient has high white blood cells? What's the term that we use?
Leukocytosis.
Leukocytosis. Perfect. So this patient has leukocytosis. Perfect. Now let's look at the RBCs. RBCs high or low? RBCs, the normal range is 4 to 5.2. So RBCs are low. So what's the term that we use?
Oligocythemia.
RBCs. Low RBCs. Anemia. Anemia. Just calling it anemia. Okay. And then the patient here has 6.1 hemoglobin, which they're saying the patient has anemia.
Normochromic anemia.
We're going to look at that right now. So the patient's MCV is 89.6. Is that microcytic, macrocytic, normocytic? What is it? Normocytic. Perfect. And then after that, we start looking at the MCH. So the MCH should range from 23 to 31. So this is normal. MCHC, this is normal. The RDW is high. So what do we call it? What do we say this patient has if they have a high RDW? What's the term? Anisocytosis. Perfect. So the patient has anisocytosis. Perfect. Okay. So that's it. Okay. And then we move down to the white blood cell differential. So as you remember, never let me eat bananas. Even that's the order. Never let me eat bananas. So never is supposed to be around 60. And he even give us the range at this point. So 59, that falls within range. 30 falls within range. Monocytosis supposed to be average is 6. We said it's like 2 to 11. So that's okay. 10.5 is okay. Eosinophils, that's low. They have low eosinophils. Basophils, that's normal. So you're going to say that the patient has low eosinophils. So remember, within the exam, you have to read everything. You have to read everything and comment on everything, okay? Okay. So let's look at this patient. Now, neutrophils, 28.3. High, low, normal. What is that? Neutrophils at 28.3. That's very low. That's very low. Neutropenia, perfect. So we call that neutropenia, perfect. Now, lymphocytes, they're at 1.4. This guy has 1.4% lymphocytes. What do we call that? Now remember, never let me eat bananas. There was 60, 30. That was supposed to be 20 to 40%. This patient has 1.4. This is absolutely low. The patient has lymphopenia. And then this was supposed to be around 6%. And we said the acceptable range is 2 to 11%. So this is okay. Eosinophils, 64.6%. This should be 3%. It's 64.6%. What do we call this? The eosinophils are at this range. Eosinophilia. Perfect. Basophils are at 0.7%, lower than 1. That is normal. Okay. Then we start looking at the RBCs. So now we look at the RBCs. The range, the number is 2.4. Now remember, we don't have to remember. It's giving you the range here for this patient. It's 4.5 to 5.5. This patient has anemia. Perfect. Now hemoglobin also shows it. We don't need to look at the hematocrit. The MCV is 86. So that is normal. The average range is 80 to 100. Now we look at the MCH, in this case, the mean corpuscular hemoglobin, and it says here it's 33. It's a little bit higher. Okay, it's a little bit higher. It should be up to 32. So what do we call this patient?
Normocytic hyperchromic anemia.
You can say hyperchromic normocytic. Yes, perfect. That's it. That's the comment we'll be looking at. Perfect. MCHC is 38. So we're going to say that they have a high MCHC. The RDW is 16. The upper range is 14. So what are we going to say this patient has? If they have a high RDW beyond the upper range, what do we say? Anisocytosis, perfect. So it says that the platelets are 11,000. The range is 150,000 to 400,000. 150 to 400,000. They have 11,000. That's low. What do we call it when a patient has low platelets? Thrombocytopenia. Perfect. That's called thrombocytopenia. Perfect. So that's it. That's how you guys should address a CBC on your exam. If you're capable of writing these terms, if you're capable of looking at the ranges and knowing something is wrong, and capable of saying this is normocytic, microcytic, macrocytic anemia, if you think it's hyperchromic or whatever, this is how it works. That's all you guys need.
So here we're looking at the CBC and the differential in the peripheral blood. So here they just want you to notice that the patient has a large number of blasts, okay? So this means that they're either going through a nasty infection, or maybe they have some sort of leukemia. But it just want you to see that sometimes if you have this term here, blasts, is just showing you that something is wrong, okay? Okay. This is another patient, just showing you that it's like they took a CBC and another one 18 months later, and they're just doing a comparison. I don't think this is useful. Let's just look at the one after that. Yeah, so this one I think is because this is a real one. So let's start seeing how you guys would interpret this. So a patient has neutrophils of 5.6. Perfect. Someone told me a shift to the left. Thank you, Abir. Thank you. Perfect. So let's look at this. So neutrophils 5.6%. Is that normal for a patient to have 5.6% neutrophils? Sorry. Does that make sense? Never let me eat bananas. 60. They have 5. This should be, guys, that should be, yes, it's not normal, right? It should be 40 to 80. This guy has 5.6. They have neutropenia. Now, never let me, the L, this is 30. Now, the range should be 20 to 40. They have 94.4. This is super high, right? Okay, this is super high. Okay. They don't have any monocytes. They don't have any eosinophils. They don't have any basophils. So something's definitely wrong with this patient. Okay, this patient has leukemia. Yeah. Okay. So let's look below that. So the RBCs are 2.69. The reference range is 38 to 4.8. What is that? What do we call that? 2.69 below the reference range. What do we call that in RBCs? Anemia. Perfect. Now, we don't need to look at the hemoglobin or the hematocrit. Now, the MCV is 78.4. So we're going to call it microcytic. Perfect. Now, the mean corpuscular hemoglobin is 27.5. So is it hyperchromic? Is it hypochromic? Is it normal? Nothing's wrong with it. We're going to, it's normal, right? Not going to comment on it.
Normochromic.
Normochromic. Okay, perfect. And then the MCHC is 35.1. So we're going to say the MCHC is high. The RDW is 14.4. The upper range is 14. So we're going to say this patient has an esocytosis. Okay. Platelets are 14 or 14,000. The range is 150 to 410. So we're going to say this patient has thrombocytopenia. Okay. Excuse me. Yeah, no, we look at whenever we're discussing the color of the RBC, whether it's hyperchromic, whether it's normochromic, hyperchromic, whatever, we're usually looking at the MCH, not the MCHC. Okay, that's how we define it. Okay, so neutrophils 2.2%, definitely something wrong. I think this is the same, is it? Because I think this is just the same. Oh no, it's not. Okay, neutrophils 2.2. Someone's asking me to write everything on a report. I don't understand what does that mean? No, I don't think they even, someone's asking me, is this with absence of blast? I don't think even the lab ran, I don't think, no, it's not an absence of blast. I don't think the lab even ran a test, a differential test. I don't think so. I think it's just the basic CBC, and the differential should have been done. The reference range for neutrophils, here, they're running 2.2. They're running the reference ranges at 2 to 7. No, the reference range is for the absolute. It's not for the percentage. This is a reference range for the absolute, okay? So don't get confused. Normally, we're looking at neutrophils, okay? So we're looking at the relative. We're not looking at the absolute. So this should normally be 60. This is 2.2. It's neutropenia. This is 97%. Shouldn't be. It's 20 to 40. I can do that. I don't mind. But I think Dr. Nasr is already doing that. Someone asked me, can you write the answers and send them? I think Dr. Nasr is already doing that. So the lymphocytes, they're at 97%. So that's very high. So what do we call this patient? If someone has very high lymphocytes, what is that called? The term? Lympho what? Anyone have any idea?
Lymphocytosis.
Perfect. It's called lymphocytosis. Perfect.
Then the monocytes at 0.1, the eosinophils at 0.1. So I'd say that now the monocytes, the normal range was 2 to 11. Now this is low. The eosinophils, we said 3%, but the range is 0 to 5. So there's never going to be low. Basophils, not low. Then we look at the RBCs. RBCs is at 2.2, range is 3.8 to 4.8. So that is low. Hemoglobin. Okay, perfect. Okay. Then we look at understanding that into the hemoglobin is at 6.4. That's 12 to 15. So that's called 6.4. Hematocrit is at 18. 36 to 46. So I can just deduce from that this patient has anemia. MCV is at 83. 83 falls within normal, so it's normocytic. The MCH is at 29, still falls within normal, so it's normocytic, normochromic anemia. And then this is probably just anemia of, I think it's anemia of chronic disease. Okay. And then we look at this patient has MCHC, which is 35, higher than the normal. So we're going to comment on that MCHC is higher. We look at the RDW. This is at 17%, higher than normal. This patient has anisocytosis. Now, perfect. Platelets here is at 92. Ranges from 150 to 410. This patient has thrombocytopenia. Okay. Does anyone want to maybe take over the mic and take a guess with this? But just raise your hands. I'm going to choose anyone randomly. So does anyone want to do this? Like take this as a test for yourself. Anyone want to interpret this? So this is actually very easy. I know you guys were concerned about this. And I know that whenever we have a discussion, there's a lot to say because we have to make sense of this because we're trying to learn medicine. We're just not trying to be good test takers. But in the end, what you're required to do on your exam is quite very simple. You have to tell them that this is a CBC. Okay, so Rodina wants to share. So you can go.
Hello, doctor.
Hello, Rodina.
Okay, neutrophils is 0.2, so it's supposed to be 60, so from 40 to 80, so slow, right?
Perfect.
Okay, and lymphocytosis is high since it's supposed to be 30.
Perfect.
In between, and monocytosis is low.
So we say
6.
So monocytes are low, and the patient has neutropenia and lymphocytosis. Okay, and after that,
eosinophilia is it's normal. It's not high. It's not low or high because it ranges between 0 and 5, I believe.
Perfect. So eosinophils, perfect. So eosinophils are normal, and then basophils.
And basophils are not there.
So
not 0.
Okay, perfect.
Okay. And then red blood cells is low.
Low. So this patient has
anemia.
Anemia, perfect. Okay.
Okay. And hemoglobin 7.4. What was the range for hemoglobin? I think it's 13 to 7. Okay, so it's low too.
Okay.
See you. Okay. And hematocrit is from 80 to 100, so that's very low.
Perfect. Okay. You said hematocrit is from what? 80 to 100?
No, MCV is
from 80 to 100. Okay. MCV is from 80 to 100, so this is 82.
Yeah.
So what do we call it when it's 82, when it falls within range?
Normocytic.
Normocytic, perfect. And then we look at the MCH. So what's 28? Is that within range?
No, I think it is.
It is, yes, 27 to 32. That's the range.
Well, it's normocytic, normocytic.
Normocytic, normochromic anemia.
Normochromic, okay.
Perfect.
And the MCHC, it's normal.
It's normal, perfect.
And there is anisocytosis.
Mesocytosis, perfect, perfect. Platelets.
It's low, it's very low, so thrombocytopenia.
Perfect, very proud of you. Perfect, mashallah.
Thank you very much, thank you.
Okay, so that's more than perfect. And then here we have the last thing that we just didn't notice in this is the differential leukocytic count above here, which is the WBC. I know you might have probably thought this was the title of the page, but we didn't notice here the white blood cells says the result is a 104 and the reference is 4 to 10. So this patient also has severe leukocytosis. So that we could have just said that as well. So I think Matthew wants to take over the mic. So you can take over the mic if you want.
Doctor, I have a question for the exam.
Yes.
if the CBC shows high white blood cells and platelets count, do I have to mention the provisional diagnosis, although the
No.
red blood cell count is normal?
No,
Or I don't.
you don't have to reach a provisional diagnosis. That's not what we're trying. That's not what we're looking for. You just need to say, you need to be able to comment, like write a good comment. Just say, oh, there is lymphocytosis, there's thrombocytopenia, there's microcytic hypochromic anemia. That's what you need to do on this course. Nothing more than that. You don't have to say this is this patient has iron deficiency anemia, or this patient has anemia of chronic disease, or this patient has sideroblastic anemia. That's not what we're looking for. It's
As I've already said that the type of anemia is required in the exam. So if the MCV is below 80, so I have to mention that's microcytic anemia, and the next step is I do the iron studies to know that is not iron deficiency anemia or not.
yes, perfect.
So
if they ask what's the next step, then say you have to do iron studies. If it's macrocytic, what's the next step? We're going to do B12, and we're going to do folic acid.
But I don't have to mention the diagnosis and the exam.
No, you don't. Don't worry. Okay.
Okay.
I think this is much easier now that when you approach it this way, it's much easier. Just need to look at the reference ranges and know some terms. That's it. Okay, so I think Nancy wants to do the last one, or the one. No, that's not the last one, but Nancy wants to do this one. So please take over the mic.
Okay, the total white blood cells, it shows us that there's leukocytosis in general, but then when we gone to each type of them, neutrophils, they are low, so it's neutropenia. Lymphocytes are also low, so there is lymphopenia. Monocytes, it's from 2 to 6, was it? Yeah. So
but I would also look at the absolute with the reference. So the absolute is 0.6, and the reference we're given is 0.221. So we're gonna say
okay.
Yeah.
Okay. There's a problem in my phone. I'm sorry.
Worries. So I'm gonna zoom a little bit. So these are blast cells. So I have 80 blast cells. Is that normal?
No, it's not normal. That means there's a problem in the bone marrow. Maybe it's leukemia or something else.
So what do we call this? What's the term that we're gonna write on the exam?
Lymphoid leukemia. Lymphoid leukemia.
We're gonna say shift to the left. Perfect. We're gonna say a shift to the left. Perfect. Okay, then let's look at the blood cells.
Okay, the RBCs are low, so there's anemia. Hemoglobin also low, it's expected. The MCV is low, so it's a microcytic. The MCH is low, so it's a hypochromic. The RDW, it's normal. Platelets are low, so there is a thrombocytopenia. So there is bicytopenia because there's anemia.
Don't forget to comment on the MCHC. You guys don't need to say bi. I don't know why.
I don't know. Dr. Mohammed Nasr emphasized on this.
He's a hematologist, so he's capable of using these expert terms, but you guys don't need to go that far. Just need to say that. You don't need to go that far.
Okay, how do we comment on the MCHC? What do we say?
Say it's high. Higher than
it's high. It's high.
Perfect. Okay, so who wants to do the last one before we move? Who wants to do the last one? Or should I do it? Okay, I'll do this one. So the last one, it says here that the hemoglobin is at 10. The reference range we're given is 25 to 17.5, so it's low. So the patient has anemia. Now the hematocrit is at 31.4. We're given a reference range of 41 to 52, so the hematocrit is also low. Now we already established this patient has anemia. Now let's move on to look at and this is where I kept telling you guys, you don't need to have all three to say the patient has anemia. So this patient has a normal blood count for the RBCs. So it's 5.2, which falls within the normal range, but they still have anemia, okay? And then we start looking at the MCV. So the MCV is 59.9.
which is way below the range, which is 1800. So we're going to say this patient has microcytic anemia. Now, is it microcytic hypochromic? So the MCH is 19. Now, normally this should be 27 to 33 according to the reference range. So we're going to say this patient has hypochromic anemia or hypochromic microcytic anemia. Then we're going to look at the RDW, which is given as 18.5. However, it should be between 11.5 to 15. So we're going to say this patient has anisocytosis. The platelet count we're given is 2 to 4,000 or 2 to 124,000. The reference range is 150 to 450. So yeah, that's the reference range. Then the total leukocytic count we're given is 20.3. And that is much higher than the reference range. It's 4 to 11,000. We're given 20.3 thousand. This patient has leukopenia. Okay. And so that's about here. So the neutrophils we're given are 25%. Neutrophils should be around 60, which is 40 to 80. So this is low. So we have neutropenia and we have some non-segmented cells. So we're going to say that there's a shift to the left. Here we're going to see that there's lymphocytes at 65. They should range from 20 to 40. So the patient has lymphocytosis. The monocytes are given as 6, so that's normal. The eosinophils are given as 4, so that's normal. The basophils are given as 0, so that's normal. So that's about it. That's what we need to do. Now, if you want to tell what this patient should do, then this patient has microcytic hypochromic anemia. So yes, we should do some serum iron studies or see some iron profile for this patient. Okay, now that's about it.